Good evening and welcome to Psych Incubator's Eminent Psychotherapists Revealed, a production of Strategic Psychotherapeutics. We are pleased to have Dr. Marilyn Sanders with us tonight. I will tell you about her in a minute, but I also want to introduce Dr. Carlene Davidson, who is serving as a co-host tonight. Carlene, we're very pleased to have you join our team and hope you enjoy this experience and decide to be one of our regular co-hosts.
Thank you for having me.
Marilyn has done amazing work over her career. She is a board-certified pediatrician and neonatologist. She cares for critically ill babies, infants, and their families at Connecticut Children's Medical Center in the intensive care unit at Hartford, Connecticut. She did her pediatric residency at the University of Connecticut School of Medicine and her fellowship in neonatology and perinatal medicine at Johns Hopkins School of Medicine. She's a professor of pediatrics at the University of Connecticut School of Medicine. She is a very esteemed resident supervisor and teacher, and she also provides neurodevelopmental follow-up for babies and infants up to 3 years old. Her scholarly interests include providing trauma-informed care to hospitalized newborns, infants, young children, and their families. Her scholarly focus is on the impact of the autonomic nervous system's sense of safety, danger, or life threat on our emotions and behavior. She lectures throughout the United States and Europe. She has authored papers. A long time ago, she did a book review for a journal that is no longer in existence, but was a wonderful book review on Stephen Porges' book on polyvagal theory. And she has co-authored her own book with Dr. George Thompson entitled The Polyvagal Theory and the Developing Child, Strengthening Systems of Care for Kids, Families, and Communities, which was released in 2021 by Norton. This book discusses implications of polyvagal theory for the well-being and development of infants. I know, Marilyn, you're working on another book, tentatively titled Nobody Ever Called It Trauma, Metabolizing Suffering, Grief, and Loss in Medical Trauma in Infants and Children, and I'm really looking forward to that book. So, Marilyn, welcome to Eminent Psychotherapists Revealed. We are looking forward to spending some time hearing about your work.
Lovely. Thank you, Jeff.
Thank you. Okay, Marilyn. So we'll start off with what got you interested in neonatology. Mouthful.
Well, I started off by thinking about things that were very far away from neonatology. When I first started medical school, and I was not a person who was likely to go into medicine because of my other interests, but that's a story in and of itself, I thought that I would do internal medicine. And I guess I thought that I would do internal medicine because it seemed very grown up. And then I did my pediatric rotation. And I discovered that, frankly, I liked pediatricians a lot more than I liked internists. And I liked working with children a lot more than I liked working with adults. Because the beautiful thing about children was that some kid could be getting chemotherapy and barfing their guts out one day, and the next day they were running around the unit and having a great time. And I just found their resilience really inspiring. I liked working with the families. And when I was training, there were really two options for people who like to do acute care. There was neonatology and there was pediatric intensive care. And pediatric intensive care at that time dealt mostly with a lot of trauma and I mean physical trauma, car accidents, drunk drivers, stuff like that. And a little bit of other stuff, near drownings, awful stuff. And neonatology dealt with babies, some of whom were very sad, but many of whom had a great future. And so I decided to go into neonatology. And when I did that, and I told people, they had an interesting reaction, which was, you didn't seem to hate it like the rest of us did. And here I am, 40 years later.
Oh, nice. Okay.
Yeah.
And so as I think about the NICU unit and working with babies that are most vulnerable, I'm curious as to what sparks your curiosity when you first meet mom who is, or parents who are with their babies in the NICU? What are some things you're curious about as you interacting with these families?
Yeah, that's a great
Yeah,
question
yeah.
because I find myself eternally curious about who they are.
Yeah.
And so I will often engage them first in a discussion about, unless it's an emergency, I'm not talking about in a code, but I like to ask people about things like a tattoo or a piece of jewelry or how they chose their baby's name. Or I many times will just ask people, what they do. And I just find that that kind of an icebreaker, showing an interest in who they are and who their baby is, often really helps to develop a relationship. When I was, well, I still work at a community hospital that is pretty much equally divided between Red Sox fans and Yankee fans. And at one point I wore a Yankee lanyard simply because so many people commented on it, whether they were Yankee fans or Red Sox fans. I mean, it's a way of engaging.
So getting right at the heart of the social engagement system, right?
I try.
Yeah.
I try.
Yeah.
Yeah.
Hmm?
They're having I noticed raising my children that the periods when they were very small, in a stroller or something like that, they were the best icebreaker around. Everyone felt
Absolutely.
comfortable going up to see a baby, maybe a pet a little more because they're obviously
Mhm.
even cuter in some ways, but everybody's your friend then. And when you don't have that baby with you, people are a little standoffish.
Yeah, and it's different in different cultures
Mhm.
as well. I'm a Midwesterner, and so I will approach people, I think, a lot more easily than a lot of people on the Eastern Seaboard. And sometimes I'm taken aback by people who look at me as if my intention is to harm their child when I notice their child. But yeah, no, babies are great icebreakers. No question about it.
I think also, Marilyn, what you describe is that you're showing that your first interaction isn't to talk about the what's wrong, right?
Yeah.
Or the things that they're most worried about, but it's to say, I see you, right? And this is, you're human, you're here, humanity to humanity.
You're
And I
not
think
just a
that's,
patient,
you're
right?
not just a patient, right? And so I'm interested in you, and
Yeah.
I'm here to support you in some capacity. So yeah.
I had to learn that
Yeah,
because I
sure.
think that as caregivers, as healthcare professionals, as we all are, the tendency, particularly in this era of such limited time for interactions with families or with patients, even, there's this tendency to kind of get to the point, right? I'm going to get to the point. What's wrong? What are we going to do? But that often doesn't work, particularly in a field like mine, where parents often have it up to here with hearing everything about what's wrong with their baby, and they just shut down. They simply shut down. And so if you can show them that curiosity and interest, both in them and their baby, it takes you a long way, particularly when difficult discussions have to happen.
So how do you manage the time for doing all that?
Sometimes not very well. One of the reasons that I went into hospital-based medicine, and particularly into inpatient medicine, is that I do not have a temperament that would be able to deal with the productivity standards in today's outpatient practices. I simply could not do it, would be unable to do it. So I have to make decisions about how I spend my time. Sometimes I spend a long period of time with families if there's a lot of things going on, communication needs to be clarified, we're planning things, and sometimes it's just a brief interaction at the bedside. But the beauty of where I work is that I call the shots in terms of how I spend my time, not, not some bean counter.
Mm, mhm.
So when the social engagement system is working, seems so obvious. Everybody is oohing and eyeing. And I've talked about this a number of times on the program about my experience watching Beatrice Beebe's early infant maternal attachment
Mhm.
tapes
Mhm.
and remembering being at Austin Riggs for one of their Friday night seminars where she was presenting.
Mhm.
And I think she started out with a secure attached baby,
Mhm.
and everyone in the audience was, ooh, it lights us up in some kind of powerful limbic, delicious kind of way.
Mhm.
And she shows an anxious and then a disorganized attachment
Mm.
where the maternal figure, where the mother is trying to deal with the distressed kid by
Mm.
actually distressing the kid more because it's so I guess the question is how do you
Mhm.
mean when it's easy with the ones that we go ooh and ah for because it's like that's not work, that's just pleasure. But
Right.
when it's the anxious and insecurely attached ones or disorganized ones, what do you do, Marilyn, to like
Mhm.
what are your actual strategies in the moment in the room to do you recognize it immediately? And I just want to know what goes on in your head because I know when you're with a securely attached, good neuroception of safety, it goes well. But then, so tell me about the others.
Yeah. So I think that obviously the disorganized are the most challenging. And
Why?
why? Because they are they're here, they're there, they're everywhere. There's no theme, there's no thematic kind of content to that. There's no coherence to that. One moment they might be higher than a kite, the next moment, everything is awful. Um, those are very challenging. And I think that for both those and the anxious parents, what I think I do, and it'd be interesting to know people who what people would say who watch me, is I slow way down, which is very difficult for me because I'm fast. I move
So
quickly.
you pace it down.
I pace down.
Okay.
So I think that I speak more slowly. I speak quietly. If it's an anxious parent, when I'm sitting with parents, and this is so guided by culture, okay? I mean, we all know that there are certain cultures, I'm very physical, very physical. And so if I feel like I am getting, if my own neuroception is that the person is open to physical touch, I might even actually sit close enough to them to be touching them. And what I try to do is basically I try to co-regulate them by bringing my own pace down, by allowing my own social engagement system to recognize where they're at. And if they, for example, if they're angry, let them be angry. Okay, let them be angry. They can be angry. They can tell me whatever it is they need to tell me. I am not going to personalize this. A lot of the people that I work with are very disenfranchised from the healthcare system. They have a tendency just not to show up often. I also will tell them things that I see in their baby that I appreciate. And I try to always name it when I see them interacting with their baby in such a way that you can feel that there is a potential there to turn things around. Now, one of the really difficult things about my work is that it's great to ooh and ah over a 9-pound full-term baby. But when you have a 750-gram translation, just under 2-pound, 27-weeker, they do not have the same kind of responsivity. So I think what you have to do in those situations is you catch moments, you catch Kodak moments where you can see that baby responding to that family, and you build on it.
Can I circle back to, so how do you not feel the contagion of someone's emotional dysregulation? Like what do you actually do
Mm-hmm.
in the moment? I'm thinking about a patient I had that
Okay.
a young kid that in a family who was taking my bookshelves apart and looking at my manuals and taking my clock apart and it was like, oh my God. And this was a kid that was had been abused. He was provoking his father, and he was, I think, actively trying to provoke me to see if I would act like his father. And
Mm-hmm.
and I was thinking, how do you not get dysregulated when someone's emotional dysregulation and their perception of you as dangerous is so there? Like, what do you do?
Well, I probably do exactly what you do. I feel dysregulated and don't show it, right? Because I think that's what you have to do. I get dysregulated.
So you use frontal lobe to say, okay,
Absolutely.
I want to kill this kid like his father does, but I'm going to not let my impulse override my
Yeah. I
yeah.
use my prefrontal cortex, right? I use my frontal lobe and my prefrontal cortex to um, um, basically suppress the instinct to
So
do something.
how does polyvagal theory
Sure.
inform us? Like what do you take from that in terms of what we're talking about?
Okay,
If you
sure.
could elaborate on that a little bit,
Sure. So I think, when you're talking about that kind of kid, I've got to talk about both polyvagal theory and Bruce Perry, right?
please.
Because this is really Bruce Perry's neuromaturational model that you're talking about there with, and I don't know the
Can
kids.
you say something about that?
Sure. So Bruce Perry, who has an institute in Houston, I believe it
So
is.
he's a neuroscientist
Psychiatrist.
and
Yes.
psychiatrist.
Psychiatrist. Bruce is a psychiatrist who has worked for many, many years. Do you know Bruce, Michael?
I've read a lot of his stuff.
Yeah.
He gets somebody, someone
Yeah.
who could relate to the child and calm the child.
Right.
Um,
So what Bruce Perry has done, which is really brilliant, and I encourage anybody who works with dysregulated children, and to some extent dysregulated adults as well, to read Bruce's work, because in the neuromaturational model, he literally maps out where this child is at. He works only with children, where this child is at in terms of what level of function and dysfunction do they have. So Bruce Perry would say that that child is probably functioning at the brainstem and limbic level, and no higher than that. And what Bruce has always said is you can't address the frontal cortex until you've addressed the brainstem and the limbic system. And I don't know that much about specific techniques that he uses, other than he uses a lot of things for these very, very difficult children, things like swings that give a lot of sensory feedback, because what that kid is doing partly is he's sensory seeking, right? I mean, it seems like it.
Yeah.
And so I would
So
say,
what does that mean?
he's looking for, so when we say that we're sensory seeking, we are looking for sensory feedback. Okay?
Because
Because of dysregulation and because of not feeling, and I'm getting a little out of my
wheelhouse.
wheelhouse. Thank you. Wheelhouse right now. But because I'm, as you know, not a therapist. But when you we are all sensory seeking, but for most of us, the kind of sensory feedback that we need is in somewhere around, if you think about a bell-shaped curve, we're within 1 to 2 standard deviations, right? These kids, for whatever reason, with whatever degree of dysregulation they have. So when you think about it like that, and this is, I think, where you can think about polyvagal theory coming in. So you can think about the kids who are all the way at the bottom, and those are the kids who are totally shut down, right? They don't even look for sensory feedback. They are just shut down. The Romanian orphanage kids,
So
because
that's like a worst
case scenario, right? Worst case scenario. And then on the other hand, so if you think about 1 standard deviation to 2 standard deviations, there you've kind of got your ADHD kids, right? The ADHD with hyperactivity. So they're on the move, they're touching walls, they're touching people around them to get the feedback, the sensory feedback that they cannot get through typical social engagement. And then way at the other end, you've got the kind of kid that you're talking about, or close to the other end. So, boy, that is a really difficult situation. Carlene, do you have anything you can add to that? Because this is more your wheelhouse.
Sure. I think, as you were saying, is that what you want to recognize what's happening in terms of their autonomic nervous system, right? And so they're in the space of how to integrate what is happening in terms of their sensation, right? And what's happening with the environment. So this feedback loop is taking place, and they're really trying to, in a very disorganized way, to see what is going to work, what is going to kind of quell, to bring down. So what the environment needs to do, or the parent needs to do, or us being the provider, is to recognize those cues, and that we then can mirror what are some ways to integrate these sensory experiences that are happening, right? So that is the goal, is to help to integrate that, because they're naturally wanting to be able to do that and trying their very best to figure out how to do so. So we can think about it as this kid is being disruptive and, and being aggressive and all these other stigmatized and label, or we can look at it through the nervous system, the autonomic nervous system, to say, aha, what is getting activated, and what are ways they're trying to settle that activation down.
Interesting.
Do you know about sensory integration workups, Jeff?
No.
Okay, so there's a whole field of experts who are typically occupational therapists, and they do sensory integration workups that look at both hypo and hypersensitivities. So I'll bet you that kid has both. I'll bet you he might.
Yes. Yeah.
He's the kind of kid who can't stand loud noises.
Yeah.
Right? Who would have to go to that special, I think the Yankees has a sensory box where kids can go who cannot tolerate the input from the sensory system. So I guess what I would say to you, that particular kid, see if you can get him sensory integration. How old is he?
15.
See if you can get a sensory integration workup for him. You may have to go to Boston, but it may help. But then when you, so kind of then moving into the polyvagal theory component, if you think about the social engagement system, right? And this is a child, is he autistic? No, okay. So this is a kid who, for whatever reason, cannot feel in a ventral vagal fashion, or that kind of safe, calm sense of co-regulation that most children get being in the presence of a caring adult.
Okay.
So thinking about polyvagal theory then, and kind of the evolutionary hierarchy,
Can you
when
talk about that? The ventral vagal, you said ventrovagal.
ventral vagal. So this is the parasympathetic and sympathetic system working in tandem. So when we are cool, calm, comfortable, engaged, feeling safe, and are under what we would call a ventral vagal influence. And that's
Ventrovagal?
ventral, ventral, ventral. The ventral vagal
As opposed to dorsal.
as opposed to dorsal. That's right. So remember that the vagus nerve, the 10th cranial nerve, has its cell body in the brainstem. And there are two components to it. One is a more anterior component, which is more, it is an evolutionarily more advanced component. The other is more dorsal and formed earlier. And that's what you see, for example, in collapse. So if you can't do it with social engagement and ventral vagal, you start going down the evolutionary ladder to sympathetic activation. So this kid, basically, for whatever the reason, and I suspect that you could name the triggers that cause him to go more off the wall than others. So when he gets like that, then he does this sensory seeking behavior, which is counterproductive, but Steve Porges would say it's in the service of survival, given what his nervous system is doing at that moment. And then at the bottom of the ladder is basically your dissociation, your collapse, your syncopal episodes under stress. Does he ever have those?
No.
He doesn't. Okay. Wow. He must be a real, does he sleep at night?
Yeah.
Oh, that's good. That's good. So he sounds very, very complicated. But for most of us, we're in either, unless we are faced with something that appears so life-threatening and overwhelming that we go into collapse. For most of us, we are either in ventral vagal or sympathetic activation, which really do work in tandem to meet goals. If we didn't have our sympathetic activation, we would not be able to rise to the challenge that life essentially expects of us or demands of us from time to time. So for me, when I found out about polyvagal theory, it really was sort of an explanation of things that I felt that I had seen and felt viscerally, but did not have a clear physiologic and behavioral understanding of. And one of the things that's really different about what Steve Porges does that I like is you can look up social connectedness and you can find all sorts of definitions of social connectedness. But what's different about what Steve says about social connectedness is the combination of the physiologic and behavioral co-regulation. So most people talk about social connectedness like, oh, we sit down and we are having a good time. And I feel really nice and you feel really nice and we have a nice chat, and that's behavioral. But what Steve does is bring in the physiologic component as well, which is what really makes it such a sort of a vibrant theory that I feel explains so much of what I see in life in the NICU, and it also becomes a philosophy of care. So suddenly that parent that people are constantly calling difficult, the difficult parent, right, becomes a parent who is sympathetically activated. And you are asking yourself not so much, what's wrong with them, but what happened to them, which is something you might be more used to doing than people on my side of healthcare.
So Marilyn, when we just spoke about things in terms of the neuroscience and our autonomic nervous system. So the typical parents doesn't have that. They do not have that language, correct? Would you
Mhm.
agree?
Right.
And so how then we explain that in layman's term that
Mhm.
when a parent, or let's think about the
Mhm.
child is in activation, right?
Mhm.
They're having whether it's traumatic stress activation
Mhm.
or a sympathetic activation, whatever the case might be. And the parent is then, so the child's activation is this, and then parents get activation gets bigger and bigger and bigger, right? As opposed to smaller and smaller and smaller. I'm curious as to how then you are able to explain,
Mhm.
what is happening in a way that is like, aha, like this
Yeah.
makes sense to me. And here's how I can course correct. Here's how I can regulate myself and then show up for my kiddo so they too I can support them in that, as opposed to thinking that the kid is doing it to them or any other scenario, which this is something that I think most of us can agree that we've seen, right?
Mhm.
This example. So can you walk us through how you would then do that in a way and
Mhm.
using language that the parents can really connect with?
Sure. So remember, I take care of mostly infants
Sure.
and very young children. So I talk about, because you might think about this as, how you would help parents deal with like what they might think of as a difficult or
Yeah,
colicky baby.
sure.
So I talk about behaviors.
Mhm.
And so, for example, the behaviors that we see in an infant when they are in a ventral vagal, I do not use those words when I talk to families, but when they are feeling safe and calm, I talk about how their movements are fluid. I talk about how their eyes are open and bright, how they are making eye contact with their families, for example, how they sleep well, how they breathe easily. I mean, those are all kinds of things that are consistent with a ventral vagal response.
Mhm.
Um, for babies who are kind of coming down that evolutionary hierarchy um, to a sympathetic activation, their heart rates go up, their face gets clenched and they're grimacing and they're crying in a way that's very different than the kind of the robust cry of the well-regulated infant. Um, their movements become frenetic. They're not feeding well often. They're not sleeping well often. And then sadly, at the other end, which is something I would have to say that except in a kind of a very limited kind of physiologic state, the child whose dorsal vagal or the baby whose dorsal vagal is limp, unresponsive, flaccid, depressed appearing, blank stare. If you want to see pictures like that, take out some of the Dust Bowl pictures and look at pictures of mothers and babies during the Dust Bowl.
Yeah,
You've seen them, right? And you
yeah.
see the
I
blank maternal
remember
face.
them, yes, yeah. They're embedded, yeah.
Yeah, you see the lack of tone
Mm-hmm.
in the infant. And then what we have to work with parents to do then is to get them to be able to mentalize their baby's state, right? And so one of the things that I use, there's a wonderful, sadly deceased researcher who was at Yale for many years, a woman by the name of Nancy Suchman. And Nancy was a psychologist who worked with a very difficult population, worked with a population of mothers who had substance misuse. And she developed a fairly short term, about a 12-week intervention with these mothers that was focused first on helping the mother be able to mentalize her own states and experience, and then be able to mentalize her babies. And she had really good results. Suchman, Suchman, and I would recommend those papers to anybody who's interested. When I'm talking to parents then, or lecturing to groups, for those of you who are familiar with Deb Dana's work, I use her ladder, her autonomic ladder, very frequently with parents and other adults. So, you talk about, are you guys familiar? I know you're not. Okay. So Deb has a beautiful picture where she has a picture of somebody at the top of a ladder who's in ventral vagal, right? They're looking out, the world is good, they got this under control. And then talks about how as we move down this phylogenetic hierarchy, which starts at the top with ventral vagal, we drop down the ladder to sympathetic activation. And if we are really totally overwhelmed in what feels like a life-threatening situation, collapse. And she has a figure at the bottom of the ladder. And I find that graphic.
There are three rungs.
Well, the ladder has rungs, and then there's the ventral vagal at the top. Halfway down is sympathetic activation, and at the bottom is dorsal vagal collapse. And I find that people can identify, I can use all sorts of fancy words, right? We can all use all sorts of fancy words, but everybody can identify with a picture like that, what it means to feel on top of the world, and then you're tumbling, and then you're at the bottom.
You're talking about some of these things, about how the therapist or the evaluator, whoever it is, recognizes that there's a problem here, and it has to help this parental figure get in touch with what it's like to be with this child. And then they begin to develop the skills they need to hopefully work, or someone helps them with that, do that for their child. It's parallel to what a lot of us do in treatment with older people. You have to put yourself in their shoes, and some of them like that and really make use of it, and some hate it. And then you have to have a strategy for that, but you have to develop somewhere, figure out what it is that lets them be in touch with the feelings involved in caring for a child or a pet or something that needs them. And now the reward for that is obvious to anyone who's a parent or has pets or likes children. I mean, nothing feels quite as good as making that connection. And so when you get it, then there's a bullseye, and parent is your buddy, and you can do the next part. But that can be very hard, because so many people, have been so traumatized that it. So that's that analogy works for you.
Yeah.
For what you're doing. Okay.
Yeah, and not in the same way that not every patient resonates with every therapist, not every parent resonates with me. So you have to accept that, and in my case, they don't have a choice. See, in your case, they can decide, Michael, I'm not resonating with you, and I'm going to look for another therapist. In my situation, they can't, because whoever is the attending is the attending. And I think that's one of the great challenges of the work we do. We meet people. For many people, this is the worst crisis of their life. They have a sick child, right? And there are very few things that, I mean, if you want to look at number one stressors and causes of divorce, what's right at the top? Loss of a child.
Mhm.
above loss of a spouse. So we meet them at this horrible crisis. Many times they have had a totally uneventful pregnancy prior to whatever it is that has happened. And so I am going into that room to meet this family when their world has just fallen apart. And you do the best you can. And I know that over the years, I think the vast majority of parents have liked me. And shoot. And some, just turning something off here. Some have just tolerated me. And, you know, we have to accept that that might be the case, that sometimes they may just tolerate me, and I do the best I can, and I use whatever seems like it might work. But most important, I'm honest and authentic because there's nothing else to be.
Yeah. And Marilyn, I'm wondering about continuity of care. So when you are not on the unit, right? So you've set this tone with the family, you've given some of that education, that psychoeducation. And so when you're not present, and I know some of your work is really with you know, having a polyvagal inform training for the medical
Mhm.
folks, so the nurses, the students, the interns. So I wonder what has been that, you know, in terms of reception. And when we think about that continuity of care, when we're
Yeah.
thinking about, which
Yeah.
kind of may go against some of the initial training. So can you tell us a little bit about how you facilitate and how you foster
Mm.
some of that continuity of care?
So it is very difficult.
Yeah.
Medicine is inherently conservative. And I'm very sorry to say that Steve Borges has had much better uptake in psychology than in medicine. But we keep plugging along. So I will often use these kind of general thoughts about helping people appreciate what at least my sense of the neuroception of a parent is, or even a neuroception of a baby, but that's even a totally different topic. And I actually drop in a lot. So I will drop in and say hello to people. Once people are discharged, I have many families who stay in contact with me. So I try to carry it through. I also see some of these babies in neurodevelopmental follow-up. And I do a fair amount of palliative care, and I keep in touch with those families after. You do the best you can, right? You can't, just as therapists, you would love to be able to help everybody who comes your way. I have to accept that there are some limits on my time and energy, and I try to use it well. And I think there are the uptake when I talk to people on an individual basis, for example, among nursing, is often very good. The whole, when you start talking about continuity in medicine at this point, it's a very difficult thing to accomplish. Just like it's very difficult to get into your internist for your yearly physical unless you call 17 months ahead of time, right? Medicine has not gone in a good direction when it comes to functioning as medical homes for people and availability. I
So
wish.
why do you think that the uptake in the medical community has not been that robust, since this is a very well grounded theory that's physiologically based?
Yeah. So I think, Jeff, It is asking people to change the framework with which they view their job in the medical profession. So it's asking them, a lot of them would say, you just want me to do more with less. So now you want me to think about, what their autonomic nervous system is saying to them in the moment in this interaction.
It,
And
it seems so helpful in terms of so many of the patients that I get from the medical practitioners, that particularly the ones with chronic fatigue syndrome, fibromyalgia, autoimmune disorders, people that have been
yeah,
in chronic stress from the time they were probably in the neonatal unit, maybe, or after that, they go through that, and in collapse. I mean, people
yeah,
who just are
yeah,
in bed and can't move. And
yeah.
it seems like such a helpful framework to begin to actually formulate some treatment ideas about what you do with people
Mhm.
based on the how this theory illuminates what's going on at a neurophysiological level.
Yeah. So medicine is very structured in terms of how they approach education in many levels. So I have offered, I go many places to lecture, but rarely to medical schools, because medical schools have a particular educational structure, and Michael knows this very well, that is focused on the boards. What do you need to know to pass the boards? Because your board passage rate is considered to be a reflection of your education. And so the entire curriculum is typically structured around what you need to pass the boards. And you don't need to know much of anything about social emotional well-being to pass the boards. You need to go about cardiovascular physiology, renal physiology, endocrinology, the list goes on and on and on. So that's how they've structured it. And then you also have very limited time in the outpatient setting. And believe me, I think there are some absolutely marvelous physicians out there who do a marvelous job of doing this, but at a sort of a professional level, they feel, I suspect, remember, I don't do ambulatory medicine, I suspect they think that they have enough boxes to check on Epic, and that it is very hard for them to understand that if they just spend that 5 minutes being human, it may actually benefit both the patient and them. I don't have a better explanation, and I'm sad to give you that explanation. And it makes it sound like I don't think a lot of my profession, and I actually do.
Oh, you're right, but there are many different causes, many things that drive
Sure
into
there
it.
are.
And the I think the more you go about, if you're touching your patient or you're coming and dropping in, you're demonstrating in many ways your concern for them.
Mhm.
And hopefully that's people who are going to think that's wonderful, and not that you're doing something inappropriate. But there's always an outlier, somebody who doesn't want any part of it.
Yeah.
Yeah. But the more you do these things, the better you feel. The more
Mm.
whether if it's someone parent who's just learned something horrible and is crying, and you see their face and you see their eyes fill, and you end up crying too because you've joined with them on it.
Mhm.
And the more you do that during the day, the more you connect with people. And
Well, I think
that
it's
will,
why I'm still doing this after 40 years. Because, you know, I don't need to tell you guys the burnout rate among physicians. You see them in your offices. And it's interesting. Women retire earlier than men, typically women physicians. Average age is around 57, and they often cite family responsibilities as one of the reasons for their retirements. And I just feel sad for them. I really do, because somehow, despite the incredible privilege of what we do and the many opportunities, and maybe they didn't choose well for themselves. I will say that. I think I chose very well for myself in doing hospital-based medicine. I don't have any productivity expectations. But I think for many of them, I mean, I have dear friends who are still practicing, and in family medicine, for example, that have very high productivity demands, and women often see more women and children who take longer, but they don't adjust the productivity expectations. So it's very interesting. Very interesting.
And I think one of the things that with that conversation, it's like, so how might we integrate these different disciplines, right?
Mhm.
And so we're saying that we see more of a buy-in from, the clinical world, and we're seeing more robust researched clinical trials that's looking at really understanding, Paul, using the lens of polyvagal and how for interventions or just neuroscience based interventions in general. And so I'm wondering that, we get referrals from medical, we get referrals from all sorts of resources. And one of the big thing that we're charged with as psychologists, to be the holder of so much information and
Yeah.
to navigate. And so there is more of a holistic, as opposed to I'm over here doing this, you're over here doing that. And so I'm wondering, how might we bridge that in terms of, as we're communicating with specialists, medical specialists, and where the trend is, I'm only, narrowly focusing on what I need to do. And so being a specialist yourself, are there any guidance or tips in how to, bridge some of that communication and some of that buy-in to, how we really looking at this as
Sure.
more holistic, more integrative?
Yeah, a couple of things.
Mhm.
First of all, vis-a-vis what you guys do, and I encourage all of you, when you do intakes with patients, to ask about birth histories. Please ask about birth histories, because if you don't ask, they may not tell you. You may spur them to think about, oh yeah, my mother said that. But I think doing exactly what we're doing tonight. So this is Eminent Psychotherapists. I am not a psychotherapist, but Jeff invited me to speak. I have always lived in a world in which there was free flow between mental health and medicine. It's the way I began my practice. It's the way I will end my practice. And some of that was just being in the right place at the right time. But I do also think that there are opportunities. There was something that we used to have down at Connecticut Children's, where I work, called the Medical Legal Partnership. It still exists, but it doesn't exist in the way that it used to exist when I was in my salad years as a neonatologist. So we used to have a very well-known local child psychiatrist, me, an attorney, the folks who did the child abuse and neglect evaluations, and sundry other people. And we used to meet once a month to talk about challenging situations. It was, anybody could bring a case. A general pediatrician could bring a case. Jeff, you could have brought that young man to this group. And, sometimes there were child welfare issues involved, other times not. But it was a place where people could join to talk openly and freely and to get advice on challenging situations. And I think that in a way that almost defies where medicine and mental health are headed, right? Because we're all siloed. I'd like to see more of those things brought back.
So if I could respond to that, I think this is something I'm very interested in at this point in my life. And the way that I sort of break it down, and what I'm very interested in working on now is, number one, how to teach people how to do teamwork, which to me it inoculates us against burnout. And the other is how to create communities of learning. And that, I think, is going to take a lot of us putting our heads together, because everyone is so busy and there's so much information out there, are inundated with it. And I think a lot of people respond to the feeling of being inundated with all this information by just avoiding it. And so we need groups of people to come together to curate and distill and provide a formats like this for people to do what we're doing and to inspire the next generation in the joy of learning, knowledge acquisition, and building expertise, because that's what I think has prevented me from burning out. Continuous learning, teamwork.
Absolutely.
What do you think, Michael?
I think that hopefully a lot of people who left early, as you said, or people who are leaving now, or people who are going to be not letting go. I mean, there's an awful lot of gratification from working with people who are still in training, or people who have been training for a long time and have difficult cases, finding groups that are discussing the case and bringing different points of view in. I know that, like today, I was wondering if we were going to talk about the work of the different parts of the autonomic nervous system, and how there's so much research on it now with which molecule on the cell body is causing the problem, and how another molecule that's supposed to come in and stop it isn't doing it, and how you then find a way of, they're doing it with mice now, that come back in and get rid of the destructive protein. And it's turning a lot of fields on their heads in terms of what's causing it and what you do about it. And I think that's going to go probably say a lot to people who aren't medical but are doing any kind of therapy, that there are going to be more and more of these factors that everyone has to know about, because it's going to make a difference on what there's always one model of that is the biome. People are all getting intake that way, but there's also
Absolutely
on the biome, there's several layers deeper. There's these microscopic part of a cell that's people are crisping on, and finding that by doing that, then you could enter stems of that, and you have a new treatment for something that we never knew how to treat. So people with cancer, different types, people with all kinds of illnesses are going to survive, but And I think lives will improve for that. But that's, that's not going to be enough. There's going to always be tremendous need for people who want to do it a different way. And I think, but it's learning these things is fantastically interesting.
So one more question before we have to end for tonight. What would you tell young, early career people in medicine and psychology and psychiatry? What words of wisdom would you offer them?
Couple of things. If you want to do something, oh gosh, I'm so sorry about this. If you want to do something career-wise, find a way to do it. And don't allow artificial things like fill in the blank. Well, I've got this or I've got that. Just do it. I couldn't do what I do now without more advanced degrees if I were coming along now. So if you want to do academic medicine and you're young, either get an additional specialty, other advanced training, another degree. Just do it. The other thing that I would tell people, because, you know, life balance is such an issue for people these days, is don't expect to have it all. You know, be okay about having enough of it. So when I went into medicine, there were far fewer women in medicine. And I think that I have accepted that I was not going to be either the world's best doctor or the world's best mother or the world's best wife or the world's best friend, but I was going to do a good job, as good a job as I could do. And so I do feel like a lot of particularly younger people who function under the myth of having it all set themselves up for burnout and a lot of disappointment.
Dr. Marilyn Sanders, thank you so much for sharing your wisdom, your expertise, and your knowledge with us. I think you've informed us about many important things, and we'll go about our work in a much more knowledgeable way. Thank you.
Thank you, Jeff.
Thank you.